fellowship programme was about creating better dementia care. It had a particular focus, and I think we'd like to think of a slightly different way of working in terms of delivering multi-professional training and development for people who are working across a huge wide range of services and disciplines. And the whole focus of the Dementia Fellowship was to bring together that expert clinical input from people like Shubi with some skills development. And often what people find is that they say, well, we could go on the clinical update course, but we didn't actually manage to implement what we learnt because we didn't quite have the influencing skills or the change management skills. Or we went on a change management course, but I could really have done with a little bit of clinical kind of update or specialist clinical knowledge that would have helped me articulate it with that, you know, specialist in the field. So we really set out to bring together that expert clinical input with leadership skills, with the foundation of some service improvement, change management, tools and techniques, a little kit bag for people to go away with, so that we could, people could actually take the learning from the programme and implement something back in their workplace. It was very much grounded in learning from the field, so we weren't trying to kind of, you know, create something that was new and fantastic and had huge resource implications. It was very much about saying what actually works, what have we learnt already that works, that can be replicated, that can be rolled out across a wider area, that could be just tweaked a little bit in order to help make it a little bit better than it currently is. And in doing that, we took a focus from lots of different settings, but particularly we had a whole push on the primary care setting, and a cohort of people who were made up of generally from GP practices, both pharmacies who worked in practices, GPs and people who were commissioning primary care. And then we also had a focus on hospital settings as well, both in terms of the accident and emergency and urgent care part of hospitals, which can be quite tricky for people with dementia, but also other parts of the hospital setting as well, with the idea of making a connection and a network across all of those settings and disciplines that would, you know, create a foundation for this area of building better dementia care over time. So, just some facts and figures for those people who like facts and figures. We have had 3 cohorts of the programme delivered over a 15-month period. Quite a short time frame actually, given that the programmes are about 6-7 months long in duration. We've had over 75 people who've attended from a huge range of disciplines. So GPs, practice nurses, nurse practitioners, dementia leads, pharmacists. I could go on, and then many of them are in the room and they'll introduce themselves to you as they go through the day and talk about their work. But I think one of the things that we really wanted to emphasise was the benefit of interprofessional learning. You know, so learning by being with people from different disciplines, learning with people from different disciplines, and learning from them. And that was one of our real kind of foci for the programme in terms of the learning model that we used. Okay, so just to give you an overview of what the content of the programme was, we structured this in 3 modules, so that there was 3 two-day modules, the benefit of some kind of evening work as well that was a bit more relaxed, informal, opportunity to apply learning from the day. 3 themes, so 1 theme per module, with a view to bringing together some leadership and influence and service improvement skills with some clinical expertise and specialism from in the field. So we looked at good practice in dementia care, both nationally and internationally. We looked at person-centred dementia care in terms of assessment and screening, and how to engage across wide ranges of groups, both with patients and carers and families, but also engaging with different professional groups. And then we looked at care after diagnosis and moving into end-of-life care, and what the change in practice might be that was required to improve that. Intermodular tasks and reflection, so no getting away without any homework. There was a little bit of homework, not a lot, but very much grounded in what people were doing in their practice. So not saying you have to go away and look at something that's completely outside of your sphere. What we really wanted was people to say, actually, in my workplace, I could test this idea now, here and now. I could go away and have a go at it. And you know, I remember an example from one of the A&E consultants that we had said, actually, we could do that. And you know, we got an idea from one place, and I said, we could do that in our hospital. There's nothing stopping us. Nobody needs to give us permission. It's perfectly safe. It's been tested elsewhere, and actually, I have the responsibility for making those decisions. So, a real push towards very practical, easy to implement things. We had some masterclasses in the evening from expert speakers, and also at the end of the programme we've run 2 now Next Steps conferences, which is about bringing together the people across all of the cohorts for sharing, learning and spreading and adoption of different successful projects that have been implemented. We hope to continue with those. Just wanted to say a little bit about systems. One of the big challenges, I think, particularly within healthcare, although people, we all work in a health and social care field, is it's the connections and the interconnectivity that often make things work, and that's where things often fall down. So the handover from one setting to another, the handover from one department to another, the shift of care from one organisational setting to a different organisational setting, and the slightly different quality standards, rules, regulations, ways of communicating. It makes it really complicated for people who are trying to navigate the system, both those who work in it but also people who are using the care. So we really tried to focus on the interconnectedness of the system that we work with and how we managed to bring those connections together in positive ways and learning from each other. So, for example, memory clinics need to liaise with GP practices, who might need to liaise with care homes, who might need to liaise with accident and emergency units, who might need to have good relationships with families and carers. And how does all that knit together to create a good system of care? Not how do the pockets work individually, but how does it all pull together to create a good system? And just to really kind of put an emphasis on system-wide working. And I hope that people who came on the programme really felt that we were trying to kind of bring that broad spectrum into the room and have a conversation about how we could improve it. So I think I should have a little video.
I have found this course really challenging, pitched at different levels to involve us all, I think, which is really good.
I am a GP and I'm also Commissioner for Dementia and my CCG. The biggest advantage I found from this fellowship was the chance to network with my colleagues and peers who are doing the same sort of role in other areas. Another very powerful part of this fellowship is the chance to meet people who are working at a much higher level and seeing where the drive for everything that's going on in this area is coming from.
We at the medical school have a strong track record of bringing together good quality clinical input with high quality leadership and service improvement knowledge. What we wanted to do was develop the ability of all the disciplines to call on each other's expertise in order that locally the old demarcations between what a GP did, for example, and what a primary care nurse did started to fall away, and people started instead to bring together their know-how around how to improve treatment for patients locally.
As a community nurse, you sort of think of it's a them and us situation, but actually it's not. We're all in it together, really, and I think that's what it is. It's sort of working more closely together. So I suppose it has given me confidence in the sense that I know what data that they might need. I can maybe help them with that data.
So what we're seeing today is a much higher degree of comfort with each other in terms of using each other as resources, in terms of gathering around a common interest to improve local services and starting to make practical proposals for change. And this morning, for example, we've been helping people identify a real important local service improvement project that they're going to work on together, and to start taking forward ideas on who would they influence to make that happen, how would they engage patients in designing the change they want to make, what are the critical issues in terms of quality, service access, financing, and all those other key things that people often stumble over. We're seeing today that they already network and start to exchange ideas around those issues, and it's very effective for promoting an accelerated way of changing local patterns of care.
So, what's happened as a result then of people being on the Dementia Fellowship? It hasn't been just to kind of, come on a programme, have a nice chat with people while you're there, eat some fantastic lunch, in fact be fed continually while you're here, and then go away and forget about it. There's been some real tangible improvements within care in the local area. and they highlighted, I think, some of the posters that some of the Dementia Fellows put together are on the board at the back there. I've just put a little selection in here. I've by no means picked out ones in order of kind of, you know, priority of being the best projects. There were projects that were very grassroots and very much about teams within hospitals being enabled to make changes. So, for example, things like a recovery bay in accident and emergency. There were small-scale projects, but that reached across organisational boundaries. So things like, what impact does nutrition in care homes have, and how, as a GP, can I influence what's happening in care homes in terms of nutrition. And then we had projects that were more strategic. So Brighton and Hove were looking at their dementia strategy, so some strategic work. High Weald, Lewis and Havens, they were looking as well at how they interacted between the hospital setting, community, care homes and the GP practice, and had this idea of being able to fast track people, giving them this golden ticket that would give them access to different parts of the system. And we also had some projects that just kind of took on a life of their own, that started off as quite small ideas about, well, how can we educate our staff within a hospital trust, which became, well, why don't we invite families and carers along to that as well, which has kind of become a whole kind of, you know, Facebook networking page between people with dementia, their families, carers and other staff as well, around the benefits of using things like music and drama to engage people and wake up people with dementia and help them express themselves. So we've had some real tangible outputs. And finally, just to say, where do we go next with this? So really our focus on the next few months is about supporting and offering advice to enable the embedding of some of that work and the sustainability of it, but also optimising the impact of it. What aspects can we take and look at and say, what is there about what's happened in area X that's generalisable and applicable to area Y, and how can we adopt and spread some of the successes that have been had? How can we publicise and share that, again using the Dementia Fellows Network, but also other opportunities as well. There's a Facebook page that's been set up that the Dementia Fellows run themselves, and a focus on evaluating some of the interventions that have been put in place with this idea of sort of normalisation process theory. So what has become normal practice as a result of changing and embedding that, and what of that can we learn and look at and evaluate from a much more kind of scientific evaluation point of view. So that's kind of where we've got to. The network's there for you to have a look at. As I say, there's loads of people here who you can talk to. There's posters at the back there, and I'm around if anybody wants to ask questions.
Thank you very much.